Years ago, I, like you, went to a doctor, cardiologist, because I had high cholesterol, and he prescribed statins for me, Lipitor.
Yeah.
Okay, so I took the Lipitor. I took it maybe for about, I don't know, a month, and all of a sudden I started getting problems with my muscles and joints and I said, I don't think this is working for me. I don't think this is good. So what I did was I did research, and I looked, and these are some of the symptoms that you can get from statins.
Right.
So I stopped it immediately, changed my diet, and I started to walk a little more and exercise, and they always stood. They came down, but they always, stood within range of the same amount. So, can you explain to our viewers a little bit about the statins and the side effects?
Sure. First of all, statins have a bright side and a dark side. And we just have to choose the right person to treat with a statin. To treat a high cholesterol with a statin is a bad thing. I don't like to treat numbers, like I said before. I like to treat the patient. And unfortunately, your doctor was treating numbers because you don't have heart disease, because you've had ultrasounds, you've been clear here and here, so most likely you don't have coronary disease. When we look at statins, we have to look at the profile of the person and which person has the greatest to gain and the least to lose. Well, certainly any male under the age of 75, like I mentioned before, I would use a statin, but not to reduce cholesterol. See, this is the great myth about statins and cholesterol. What statins do is they happen to kill cholesterol, which the drug companies can sell, because we've propagated this myth that cholesterol causes heart disease, which I believe is a myth. And if we use a statin and it kills cholesterol, well, that's great, but statins do a lot more than that. They work on many biochemical pathways. First of all, they're antioxidants. They're anti-inflammatory. They have an effect on adhesion molecules in the blood. They thin the blood. And one of the best cholesterol studies that I've read was the West of Scotland study 25 years ago, where they took men from Scotland. They were smokers, high smokers. A lot of them had low HDLs, and a smoking male with a low HDL is a significant risk for heart disease. That's double handcuffs. And what they found was that when they used a statin, I believe there was Pravachol in that group, these men had less cardiovascular events than their controlled counterparts. And I believe it because, not because of cholesterol lowering, but because smoking and low HDL thicken the blood. They make it like red ketchup. The reason why I'm concerned with low HDLs, particularly in males, is because the blood becomes thickened. And we know that it's thick blood, red ketchup-like blood, which is highly inflammatory, which can cause clots in the brain or the heart, which is a stroke or a heart attack. So when statins were used in those high-risk men, I support it. Now, I use a statin in any male with coronary disease, regardless of his cholesterol, because of the other effects of statins. Antioxidants, anti-inflammatory, anti-adhesion molecules, thin the blood. In women with heart disease, I have not seen significant benefit, although I will use them in an occasional women with coronary disease. Do I treat women with high cholesterol? No, I don't with statins. Do I treat men with high cholesterol with statins? No. Would I treat a male or a woman with this familial hypercholesterolemia? They have this gene where they have cholesterols of, let's say, over 375 all the way up to 1,000. Well, the data in these people is mixed. If you miss a heart attack by the age of 60, you're probably going to live a long life. But if you have a heart attack before 60, your life could be curtailed. So in people with familial hypercholesterolemia, one recessive gene happens in about 1 in 500 people in our society. That's still about a few million people. Would I use a statin in those people with coenzyme Q10? The answer is yes. If they have symptoms of statins like you had, I'd pull a statin. But I would use a low-dose statin. I'm talking 1 in 500 now. I would use a low-dose statin with with CoQ10 support. Now, what about the children that have been dealt 2 recessive genes? Fortunately, it's 1 in a million. So that means there's still about 300 children a year born with this. But these children have cholesterols of way over 1,000. They have problems with receptor sites. They need liver transplants in order to survive. Mm-hmm. So that's sort of the statin story, with children. Very, very rarely will they use a statin in a child. 1 in 500 with familial hypercholesterolemia, any male with coronary disease under the age of 75, and that's about it. Because statins have a dark side. They can cause cataracts, long-term use in women, higher incidence of breast cancer, certainly musculoskeletal like you had, sexual dysfunction because of knocking down of hormones, and the list goes on and on and on. Polyneuropathy, liver dysfunction. I have had so many people, because remember, I used statins in the early 80s. And as a cardiologist, I was hearing things like, Doc, I can't play doubles tennis. I walk the dog and I get cramps in my legs. Doc, I can't get out of a chair. And back then, when I was a younger cardiologist, I didn't get it. But then after I heard the symptoms over and over again, Doc, I can't remember where I placed my keys. I'm losing my mind. I'm forgetful. These are statin side effects that people have to be privy to because it's not getting older. I had men telling me, I must be getting older, Doc. And no, it's the statin. So statins can be a blessing or a curse. There is a place for them in medicine, but instead of millions and millions of people, I'm saying a small chunk of men with coronary disease, and probably those 1 in 500 with familial hypercholesterolemia, I would use a statin.